Good evening, everybody, and happy Valentine's Day. Brave those of you that are willing to take a little bit of time away from loved ones to come and attend this excellent talk. It will also be recorded, and it's being live streamed as well for people who are struggling to log in. But I would like very much to welcome Dr. Jurgens Staats, who's here all the way from the Northwest province. And Dr. Staats is a family physician working in the JB Marks Subdistrict. That's the Potchefstroom-Ventersdorp area of the Northwest province. He used to serve as student representative on the RuDASA committee of 2009-2020, and he remains proudly rural. And we were very happy to have had him as a speaker at our last rural health conference. He's involved in emergency medicine training as an accredited instructor for RULS, he's going to tell us more about that, BLS, ACLS, and ITL. Dr. Staats also has a special interest in allergy medicine, having founded the only allergy clinics in the Northwest province. So this is going to be looking specifically at a structured approach to any emergency that comes through your door when you might be on call in your rural health facility. And I think one of the challenges quite often when you do a BLS or an ACLS or an ATLS is that it's very focused on only trauma or only cardiac or only pediatrics, where this is going to give us a general approach to any patient that walks through the door. So very, very lovely to have you here, Dr. Staats. I'll keep an eye on the chat and any issues that they might arise with sound, so I will interrupt you if there's any problems. And at the end, just to check who's on the call, we will have a feedback poll at about 6 o'clock in terms of monitoring for CPD. Oh, 6:30. Thank you very much. I'm going to hand over to you.
Thanks very much, Marlene. I can just share my screen again. And then I'm just going to do a bit of interactive engagement with the audience today. So if you, can I just confirm that you can see my screen?
Yep, it's looking perfect and we can hear you well.
All right, so if you, I'm just going to give you a few seconds to go. So you go to vbox.app. And then it's going to ask you to enter the ID number. So the number that you see there, 173-898-184, you enter that. And then as we go on, you'll be able to answer questions or interact with the things that I set up for you. So basically, my experience from rural health, especially emergency medicine, is that you end up being alone. And I always say it's utterly alone, because these emergencies come, in the middle of the night or whenever, and then you have to manage them. And it's very easy to freak out and lose your way when you're under stress, when you're dealing with something that's quite urgent. So that's why I like just a general approach. So, I can give you the lowdown now. It's A, B, C, D, E, but when people stress out, they tend to forget A, B, C, D, E, and this is just a way of building on that, because A, B, C, D, E is universal. When you go to ACLS or other courses, that's what they're going to teach you. I'm going to move on now from this slide. So if there's a slide of a question, it will give you the code. So if someone comes late, we can just help them to get on the system as well. So basically what I'm doing today is the introductory PowerPoint that we do when we run a rules course. So don't worry about too much details, but this is what we teach our people when they come to us. So I just want to start off with saying you only treat what you see, you only see what you look for, and you only look for what you know. So, you have to expand your knowledge base, because if, from family medicine, the basis of knowledge, the lowest form of knowledge, if I can put it like that, is I don't know that I don't know. Then your second step of upping your knowledge is I know that I don't know. So you become aware that you must learn something. There's some kind of gap. Then the next form of knowledge is basically where you know what you do, but you're not really there where you can teach people. But when you get to the point where you teach people, you know what you know, and you know the correct thing, and you can teach other people how to do it. That's as high as you can get in terms of knowledge and application of that. And that's what we want all our doctors to be able to do. So I'm just going to kick off with a scenario. So you're on call at the rural hospital. the ambulance phones in to say that they are bringing an unconscious vomiting patient. So the question is, how would you approach that patient? So what will you be most concerned about? And yeah, I'm going to open the polls now. You can still register in the meantime, but just, you know, just one or two words. What's the thing from that scenario that you would be most concerned about as you are waiting for that patient? So you can just type in and you know, give your response. We've still got two people thinking about it. And there's no right or wrong, it's all anonymous. So you can put anything there you want to. If you want to rub the patient's back, you can put that in, see if it really works, if it was really you. You can also put that in.
Great, and I've just noticed then people are using the chat here as well. So we've got on there some airway, aspiration, another one about aspiration.
All right, wonderful. So let's see. Takes a bit of time. Okay, yeah. So airway aspiration, what are the vitals? Loss of consciousness, aspiration, unconsciousness. Okay, so that's good. So, you know, you start to think along the lines of what the complications could be. All right, so here's some pictures. You can see some of them. You know, this picture right here, you know, they're trying to manage a C-spine as well. I don't think this is ideal to have someone lie their back and just turn the head. This one you could recovery position, and that's also people just standing around, looking around. So, you know, you must have some kind of approach and some idea of what to do. So structured approach consists of a primary survey, and in that primary survey, you need to resuscitate. You need to do something to sort out your patient. And after you've done that, you can move on to your secondary survey. And then after that, you can do your definitive management. So that initial assessment that you need to do for a patient where, you know, this is high stakes, something can happen, somebody can die, it might be a tensiomema, or it might be a pericardial effusion or tamponade or anything like that. So you need to move quickly. So primary survey, you go into resuscitation. And resuscitation, generally you assess and treat, you start with your basic life support. And then after that, you go to advanced life support. And I always say that when people come to ACLS is, if you compare BLS to ACLS, we tend to think, well, BLS is, you know, it's a minor little course. It's not that important. But thinking of that, your BLS constitutes about 60% of what you need to know to save a patient in acute cardiac arrest. Because we all know the only things that make a real difference is early defibrillation, good quality chest compressions, and reversing reversible causes. So you already get taught 2 of the 3 things in BLS that you need for ACLS. So just keep in mind that the basic things are very important in terms of resuscitation. All right, so primary survey, this is how we start. So your first concern should actually be for yourself. Hazards, hello, help. And that's what we call a South Africanism. That's what we in South Africa, the other mnemonics that people in other countries use. I know Australia use DRS, A, B, C, D, E, but we talk about triple H. And then airway, breathing, circulation, disability, exposure. So we will go briefly through all of these things. But triple H, that's where you should start off with, because you should be safe. If you don't feel safe in your environment, you ideally should not touch a patient. If you are going to be threatened by someone, or like they said in the pandemic, there's no such thing as an emergency. There's always time to put on your PPE. A vomiting patient, think of protecting yourself. Hello is very easy. it's a very nice way of just checking responsiveness. The patient looks up at you and say, "Hi, doctor." It can tell you a lot of things. So, you can already start, assessing airway and all those things. And then help. Always call for assistance. You can call for your AED or DFib. If you're somewhere, because you don't stop being a healthcare practitioner when you leave the hospital, know the local numbers. So, for example, we've got ER24 in Potchefstroom, and they've got a direct line with them. Otherwise, you're going to phone any company, and you're going to go probably to their head offices in Joburg, wherever they're situated, and then you have to explain to them where you are, which town you are. Well, when you put the local number, it's much easier to get them there. So, who would you prefer to manage your airway in an emergency setting? So, someone who knows how to intubate, someone who knows how to do a proper jaw thrust, someone who knows how to insert a surgical airway, or someone who knows how to insert an LMA. And I know it's a bit of a mean question, because I'm sure you'll probably say all four of them, which would be correct, but I'm forcing you to only pick one. All is closing. All right. So, someone who knows how to do a proper jaw thrust. So, I mean, there's no incorrect answer. I mean, ideally, it should be someone who knows how to do all four of them. But I would agree with number two, someone who knows how to do a proper jaw thrust. So, when you assess the airway, you have to ask yourself three things. Is it open or patent, which is your absolute priority? That's very, very easy and very simple to correct. I mean, if you can do a jaw thrust, you can open someone's airway, they can breathe. Is it maintainable? It's your second question. So then you have to think about this airway. Is it going to remain open? Is this patient going to be able to protect it? So you're thinking about your inhalation vents. You're thinking about someone who had a gunshot wound, and everything is open and patent now, but it might swell later. And then lastly, does a patient need to be intubated immediately? So you can see, your opening the airway is your first priority. That's the first thing that you need to sort out. And then you can go on to other things. It can also buy you some time. I mean, to intubate a patient is not just a matter of grabbing a laryngoscope and a tube and intubating a patient. I mean, there's 6 to 7 steps that you need to do to safely intubate a patient. So if you can open an airway, if you can do basic maneuvers, you can put an OPA or NPA, it's going to buy you some time to get everything in place before you intubate that patient. So again, very important skills to know when you're looking at your airway. Also remember, a patent airway versus a protected airway. So you can see here on the left, that's your patent airway. So, there's air moving from outside in, and your protected airway is a cuffed tube in the trachea. So that's just a difference. So, there's nothing more you can do to protect this airway, but this would be your easiest, most rapid step to keep the patient alive until you get to this step. You've got a bit of time to do this. And if you don't have time, then you follow the steps. All right, so just thinking of breathing, we're moving on to breathing now. Just one common breathing emergency that you can think of. Could also be anything in an emergency setting that you are facing your casualty on a regular basis. Right, I'm sorry if we're moving a bit fast, but otherwise we'll end up a bit late if we don't move on. So stab chest, acute asthma, pneumonia, pneumothorax, asthma. So you can see that it's a nice mix of trauma and medical conditions that you're listing. So you need to assess your breathing. So first of all, you're going to look at your respiratory rate. Is it too fast? Is it too slow? You're going to look at effort of breathing. So you're going to look for recession, any noises, any grunting, and then lastly, you're going to look for effectiveness of breathing. So you're going to look for hypoxia, hypercapnia, and then air entry. I mean, you're going to listen to the lungs and listen if there's proper air entry. And you need to pick up that there's something wrong with breathing. And you've got your differential diagnosis. I mean, if it's asthma, you're going to hear your wheezing, you're going to see patients in distress. If it's children, you're going to get your retractions. If it's a stabbed chest, you're going to think of either a pneumo or a tension pneumo or a pneumothorax. So there might be decreased air entry, all the signs that you're going to look for these kinds of emergencies. So just going through breathing, you need to physically look for it, because that's why we use the structured approach. Otherwise, you might focus on something else and miss the whole important thing. Patient coming in with a low blood pressure, and you start treating that patient and miss something else. Then circulation, looking at your pulse rate. Is your pulse too fast? Is the pulse too slow? Your capillary refill, very important, very nice clinical sign to pick up any version of shock. Blood pressure is also very important, your pulse pressures, and also, of course, your patient's level of consciousness. So you'll see we promote the use of AFBRI, especially in your primary survey. And when I get to disability, I'll tell you why. But at the end of the day, you need to make a decision whether your patient is shocked or not. Okay. So what is your first line management for shock? And this is what you do. I don't really care whether you give me the textbook answer or, whether you're right and wrong. I just want to get an idea of, what would you do for a patient that you've assessed as shocked? All right, so let's see what comes up. Okay, so give fluids, give oxygen, IV fluids, IV line ×2, Ringer's lactate or normal saline fluid bolus, and then someone, I guess you're not sure if you've got that emoticon. So the point that I want to make is that, there's a couple of things you can do. So remember that shock is not a diagnosis in its own. So you can either do hemorrhage control, IV access, bloods, judicious fluid resuscitation, and then you have to consider inotropes. But shock has a cause, so you need to go look at the cause of that shock. For example, if a patient's got cardiogenic shock, you're not going to give them fluids. You're going to put that patient's heart failure, over the edge. Or if it's an obstructive shock, so it's a tension, pneumothorax, or cardiac tamponade, you need to decompress that patient, or you need to relieve that tamponade. That's the treatment for it. So when you give fluids, it's not necessarily going to help that patient. You get your distributive shock, so you get your neurogenic shock, where you're going to give your fluids, but you're going to also give your inotropes. Patient in vasodilatory shock or sepsis, you're going to give them antibiotics and fluids. Anaphylaxis, you're going to give them adrenaline and fluids. So we need to think about shock and think about the cause of shock, and then you manage that cause. So, we always thought that anemia is not the diagnosis, and you can say the same for shock. So you have to think about what is causing that shock, and not just go for fluids, because I think that's that's a big gap that we have. And I also, was guilty when I started out. This, patients got a low blood pressure, let's put up an IV line, let's give fluids. And that's not always necessarily the answer to managing your patient. You can actually cause them harm. So going on to disability. So disability, you look at pupils. So look if they're equal and reactive to light. And then AFPU. So AFPU is basically the I part of your GCS. Now, the difference between AFPU and a Glasgow Coma scale is that AFPU looks at level of consciousness, while your Glasgow Coma scale looks at neurological function. So Glasgow Coma scale obviously very much a lot more detail than you would get from your AFPU score. But I don't know about you, but always, for me, it's like counting on your fingers when you're in primary school when you work out your GCS. So I know some people say there's apps that you can use to make it easier for you. But in your primary survey, I would advise that you use your AFPU in terms of just describing the level of consciousness. And I mean, there are some correspondence in terms of, if you've got a AFPU of alert, then your GCS is 15 out of 15. If it's verbal, it goes down. If it's pain, it goes down to a 7 or 8. If it's unresponsive, it corresponds with a 3. So there are some correspondences. And then lastly, don't ever forget glucose, especially with disability, these patients. You need to think about glucose. So speaking about glucose, how would you manage an unconscious adult patient with hypoglycemia? So let's see which one you would choose. So this is just a quick fire, what do you think? What do you think would be the right answer? Okay, so 50 ml or 50% dextrose. Okay, it's quite a hypertonic reaction, and you can get phlebitis from that. So if you think about dextrose necrosis, so this is what can happen if you give 50% 50 ml dextrose for a patient and that drip tissues. So be very careful the way that you give dextrose. So what we would advise is that you would dilute your dextrose. So you take 200 ml of saline and you add your 50 ml of dextrose. If you've got only the 10 ml, the 10 ml vial, you double that with saline, so you end up with 20 ml, and then you double that again, so you end up with 40 ml. And that's the safest way of giving it. And I mean, if you go look at research and how they would advise it, that you can give it straight. I mean, a lot of us give it straight just like that, but best practice would be to give it in a 10 or 12.5% concentration versus a 50% dextrose, because you can run into complications like these ones. Then exposure. So exposure, you need to expose your patient but prevent hypothermia. You need to look at bites and stings. You need to look for other signs of trauma, any rashes, any other, your fevers, all those things. I mean, there was a case, well, it's a couple of years ago now, where a patient was bitten by a mamba and he was brought into casualty. So you can imagine someone who's bitten by a mamba. It's a neurotoxic venom. So the patient had slurred speech and, he was off balance and, he was brought into casualty, and the sister's first reaction was, he's drunk, just put him in the corner. And luckily his wife was there and said, no, he was bitten by a mama, you need to pay attention to him right now. So think of these things. Not everything that comes in, we get so sensitized or so used to intoxicated patients that we tend to then just dismiss any other thing that comes in. So expose your patients, look at them, look for rashes, look for any other clues that might cause your patients to, to have certain conditions. So that's your primary survey. You need to pick things up, you need to resuscitate them, you need to do something. And then you're going to go on to your secondary survey. So that's where you're going to take your detailed history, You can do your head to toe. And remember, you're going to do a continuous re-evaluation of that patient. So standard time is that if a patient is very ill, critically ill, you re-evaluate them every 5 minutes. If they're more stable, you can re-evaluate them every 15 minutes. Because most likely, if you're in a rural hospital like where I am at Ventersdorp, you need to refer your patient. So you need to, just because you've done your primary survey and been, through all the steps, doesn't mean now that you can just let them lie there and everything is sorted, and the ambulance will come and they will remain that way until they get to where they're supposed to be. So remember to re-evaluate them and then, do definitive management. If that is within your capabilities at your facility, then do that. But otherwise, they need to be, referred as soon as possible. So applying this approach to children. So you can basically say most aspects are the same with the per kg adjustments, but remember, children are not small adults. They've got a lot of differences. So, they've got anatomical differences, they've got physiological differences, behavioral differences, because they're the ones who might, cry and scream and be inconsolable and not cooperate with you. And they might cause you to have, more difficulties in terms of assessing them. And they also have less physiological reserve. So initially they might compensate, and then they can rapidly deteriorate. They can go into hypoxia, shock, acidosis, hypothermia, death. And that's why we also advocate ABCDE. Look at the airway, listen to their breath sounds. Make sure that you don't wait too late to pick up some form of shock. Do the capillary refill time. Try to get their blood pressures. Assess all, feel their pulses so that you don't miss it, because they might, look all fine and stable. The next moment they just crash. And I mean, that's just a horrible situation to be in. And I've been in that situation before. So don't miss those things. We also use the waffles chart. So waffles is just a quick guide in terms of what calculations you can do in terms of how can you predict the average child's weight, what dose of adrenaline you should give to them, the fluid that you want to give to them, how to calculate the ET tube size and the length of the ET tube. Also, how much electricity you're going to use for defibrillation and synchronized cardioversion, if you need to come to that. And then also you need to pick up shock, because one thing that we're all very guilty is not taking blood pressures of children. So just because it's a little baby or child does not mean that you should not try to take the blood pressure. And ideally, we should have the BP cuffs available, the tiny little ones, which is something that we need to advocate for, because usually we only end up with the obesity cuff in your casualty or something like that, which makes it very difficult. But that's something that really you should not skip. Then going on to the trauma patient. So the trauma patient, we're going to use the exact same approach, but you're going to assume that there's a C-spine injury. So any trauma patient, we assume a C-spine injury. We're also going to assume significant blood loss, including concealed, and then multiple injuries, including concealed. So these concealed areas of blood loss that we're talking about the chest, we're talking about the abdomen, we're talking about the pelvis and the long bones. So you know the saying of one on the floor and four more. You have to actively look when you do your circulation assessment. You add these onto your assessment, because you have to pick them up and manage them. I mean, I always say that a fractured pelvis is the same as a tension pneumothorax. You should not pick up a fractured pelvis in X-rays. You should pick it up clinically where the patient is lying in front of you. And then if you suspect it, you can bind him and then you can send him off the X-rays. But, we had a case a couple of years ago, Potchefstroom, I was on call for anesthesia, where a patient was under a tractor, and they phoned me in because he had to go into theatre urgently. And by the time I arrived, they had just about declared him deceased. And they picked up his pelvic fracture in X-rays. So look for those things. And then multiple injuries. Patients have backs as well. They don't have fronts only. Look at the back. So, there might also be concealed injuries when the patient comes in. So expose your patient, do a log roll, know how to do a log roll. So those also, skills that you need to do, need to be able to perform when you assess these patients. So I'm just going to run this past you. So this is a case, I actually saw this now 2 Saturdays ago, literally 2 Saturdays ago. I was working in Ventersdorp and they phoned me. So there was a patient, male patient, he was in a PDA. So his car broke down and he was pushing his car along the road. And someone was driving full speed, into them from the back. So you can see that's what the car looked like. And that's what I saw in casualty. You can see his knees are straight, but his legs are twisted to the side. So he had 2 open fractures of the lower leg. He also had a open fracture of his left humerus. So when I got there, he had a blood pressure of 84/52. He had a pulse of 110. His stats was okay, 96% room air. The casualty staff was already putting up fluids for them, so they were running Voluven. I assessed him, triple H was fine. Hazards, he was responding to my voice, but otherwise he lied there with his eyes closed. His airway was open, maintainable, breathing, good air entry bilateral, didn't suspect any pneumothorax, tension thorax or anything else, broken ribs. And then his circulation, so he had a tachycardia. He responded to my voice. He had open tibial fractures, and his pelvis was stable. Looking at disability, his pupils were equal and reactive to light, and he responded to my voice. And then we did a log roll for him, and his back was clean. So I assumed he saw the car, driving towards him, and then he tried to jump out of the way, and his legs and his arms got trapped in that. So the question that I would like to ask in terms of fluid management for this patient, what would you do in your setting if you were to manage his shock, basically? Okay, so switch to ringers, lactate, and give a bolus of 20 mils per kilogram. And that's the standard that all of us would think about. So if he was, so for average mouth, so he was about average, so we say he was 70 kilograms. We would give him about 1.4 liters of ringers, right? And that's becoming kind of old-fashioned. So what we are advocating is permissive hypertension. And there's very good evidence that patients managed in terms of permissive hypertension do much, much better than patients that we give a lot of fluids for. And the reason is that we tend to be very aggressive with the fluids that we prescribe for our patients. So we kind of flush out all the clotting factors, we flush out all the platelets, eventually flush out all the red blood cells, and we're actually kind of embalming our patients. So in terms of permissive hypertension, we advocate that you only give fluids until you can feel a palpable radial pulse. So if the patient's got the blood pressure like the one here, sorry, patient with a blood pressure of 80 something over 50 something, but he's got a palpable radial pulse, you'll put up an IV line, but you're not going to push in fluids. But now the problem comes in that you get these ladies who, even when they are normal and healthy, you're not going to feel a pulse in them. So what do you do now? So if you don't feel a pulse, you look at your systolic blood pressure and your mental status. So if the systolic blood pressure is more than 90 millimeters of mercury, or the patient is still awake, then you leave them be until something happens and they deteriorate. So if the mental status deteriorates or the systolic blood pressure goes below 90, and you could not feel a palpable radial pulse from the beginning. Then you give them fluids, and then you give them small boluses, 200 mils, 500 mils, until you restore all those things. Remember, if a patient is bleeding, we don't bleed Ringus, we don't bleed saline. So we don't replace that. You can replace that with blood, but ultimately you have to address the cause. So if the patient has got bleeding sites, you can do compression on that side. Or, if the patient is bleeding from a long bone, you can try to immobilize and align the bones. But ultimately, we don't push too much fluids. And that's why something like Voluven is probably even worse, because if you give your ringers, a percentage of that ring is going to leak out into your extracellular environment, while your Voluvens, they're going to remain in the system. So they're going to push out even more of your clotting factors and all those things. So use them with a lot of caution. The only exception is in your traumatic brain injury patients. So there you're going to target systolic blood pressure of at least 100 or mean arterial pressure of 65. You need a little bit more pressure because the brain needs that fluids to come through. So you can be a little bit more adventurous with fluids, but I think a lot of people, it's just counterintuitive. We just want to give all those fluids. We just want to help those patients. We want to push something into them and make them better, but we're actually doing harm when we're doing that. Now, let me just remind you that this is a trauma case. This is a case where a patient lost blood. So don't confuse permissive hypertension with a patient who had diarrhea or vomiting or something and is now dehydrated. Then by all means, you're going to give the fluids as much as they need. But a patient who lost blood, you're going to be very conservative with the fluids that you give, up to a point where you can stop the bleed and replace blood with blood, ideally. So I really hope if there's something that you take with you from this talk, is to really look at permissive hypertension and practice that. Obviously, there's some exceptions to your ABCD approach. So one is your sugar glucose or glycogen administration. It's very important, especially when you look at your disability. So don't wait too long. Check that while you are checking your patient. If a patient is bleeding significantly, they've got an arterial bleed, or they've got, you can see they're just losing blood. I mean, there's no sense in looking at the airway, listening to the lungs, and then you're going to go to circulation and say, oh, yeah, I've noticed this patient is bleeding, but I'm only now at C. If you see a patient with what we call exsanguinating hemorrhage, you must do something about that immediately. You're going to skip AB and go directly to that. The same with anaphylaxis. So anaphylaxis, often comes with airway problems. So adrenaline is part of your airway management when it comes to anaphylaxis. That's your first thing that you should ask your assistant or sister or whoever, or do it yourself. But adrenaline is the very first thing. Then, your cardiac arrest patients, when you think of your BLS, your ACLS, obviously your defibrillation is going to take priority over all of these things. So you're not going to start with airway. When it's cardiac arrest, it's CAB. And then your epileptic patients, you need to give them benzodiazepines early, because obviously you cannot auscultate a chest for someone who's fitting, or take a blood pressure and do all those things. You need to stop the fit as soon as possible. You can give them oxygen, you can turn them on the side, you can do all those things to protect the airway. But ultimately you need to stop the fit. So this is just a summary, your primary survey, resuscitation, secondary summary, definitive. You need to treat the problem as detected, and you need to do a continuous reassessment and look at your patient's disposition. So, it would be basically impossible to give you like a thorough emergency medicine course, because the theory comes with practice. You need to have skills. You need to be able to decompress a chest. You need to be able to put in a chest drain. You need to be able to intubate the patient. You need to be able to put up IV lines or intraosseous lines. You need to know how to use a defibrillator. You need to know how to cardiovert a patient or pace a patient. So that's basically, the core of what we teach in rules. So we do expand on all of these topics, when we do the course, and we also teach these skills. But ultimately, where you are sitting in your rural hospital, you have to decide that you've got certain needs and you need to go and do some courses, because that's going to give you that confidence, those skills that you ultimately need to manage these patients. So, I've just, split them up in a couple of themes, I would guess, in courses that I think you should really consider when you are working in a rural hospital. Now, I would say at the beginning that, it's possible that I don't know about all other courses that are out there. So if I haven't mentioned a course, you're more than welcome to contact me and to update me. I mean, I always learn on a continuous basis. So please add on to these things. But just to give you an idea, so in terms of emergencies and trauma, you've got rules and FEC. So I always think about rules and FEC as paternal twins. So these are the two generalist courses that you can do, where you do medical emergencies, trauma emergencies, peds emergencies. So FEC is run by Prof. Hodgkinson at UCT, and we met up last year and we compared notes. It's very similar courses. So whichever one you have access to, go do these courses. They will give you a very nice broad approach to any emergency. Then you're sitting with something like an ITLS versus an ATLS. So ITLS is International Trauma Life Support, and ATLS, we all know, I think it's a little bit more known, ATLS. So the difference between the two of them are that ITLS incorporates pre-hospital management of patients. So it starts off with kind of your paramedic setting, where you find a patient next to the road and you make decisions according to that. And in terms of where I work, I find ITL is very useful because, for all practical reasons, we are pre-hospital. They bring them to us, we stabilize them as well as we can, and then we send them off to our referral hospital. They also, you can see there the logo, it looks like a watch. So they teach you to do that primary survey in 2 minutes. So thinking of these settings, for example, in Ventersdorp, especially on the weekend, you've got these taxi accidents and they will just come and drop off 12 patients and leave. And now you're sitting with 12 patients from an accident. And usually it's me, the first on call. Then you can call the second on call doctor and a clinical associate. So it's a few of you. I mean, the patients end up lying in maternity, they're lying in all sorts of wards. So if you can assess a patient in 2 minutes and make a decision about that patient's care, it's quite useful. Your ITLS will also teach you things like how to pack a wound, how to use a tourniquet, also in terms of very, very much about hypertensive, management or damage control. Also, the use of cyclocapron in terms of these patients. So that patient that I presented to you would also benefit from cyclocapron. If you give it within the first 3 hours, cyclocapron makes a big difference. ATLS, I think a lot of you know ATLS, excellent course. It's a little bit more doctor-centered, so they also do the ABCDE approach. They also do skills like intraosseous, central line. They do how do you interpret X-rays in trauma. They also, they do the, how would you say, they'll teach you about how to do EFAST. So they'll give you, the theoretical information about EFAST. And then African Institute of Emergency Medicine, they're kind of the new kid on the block. So they've got a course, EMAT, so Emergency Medicine Approach to Trauma, which they kind of pitch as a competitor to ACLS. And I know I've heard very good things about them. So go and check them out. They're doing interesting things, in their scope of practice. In terms of cardiac arrest, so you get your basics, so your BLS, but also remember Resuscitation Council of Southern Africa has a similar course to BLS. It's called CPR for Professionals. And then on the other side of it, the ACLS, which is also American Heart Association, but the Resuscitation Council also have a similar course called Advanced CPR for Professionals. So very similar courses from them, but the books for the Resuscitation Council are much cheaper. So think about those courses. If you want to go work on the boats and you want to go work, overseas, then, they do require you to have an American Heart Association course. And then, of course, again, you've got the twins rules and FEC in the middle, where we do teach, people how to use your defibrillator, how to identify shockable rhythm, how to shock patients. So we use the mannequin. So we use the same algorithms, but we don't go that in depth in terms of compared to ACLS. Pediatric emergencies, we all know PALS, and then there's also APLS, and then rules and the FEC also touches on pediatric emergencies. Airway courses, so African Institute of Emergency Medicine, got EMOVA, and then there's AIM at WITS. Those are the two courses I know of. I'm sure there are other courses as well, but both of them excellent courses. If you want to practice, these skills, I know EMOVA, they use animal larynxes where you do, your surgical airway. So you get to practice all these skills with them, which is very nice if you want to build up some confidence in terms of managing difficult airways and having a safe approach to airways. Ultrasound courses. So those are making a big splash now, and they are very excited when you talk about medicine courses. So they will advise you to come do this course, and I would support that. They say that your ultrasound machine is to do X-ray, and your setting might differ from mine, but our X-ray department is closed down. Our X-ray machine is broken, but we've got 3 machines, ultrasound machines in Ventersdorp. So if you do the ultrasound crash course with African Institute of Emergency Medicine, or the core point of care ultrasound with EMSA, what they will basically teach you is the following. So they will teach you how to do a EFAST. They will teach you how to do an echo. Just a brief introduction to echo. I find it quite difficult, but they will teach you that. They will teach you how to diagnose pneumonia. You can diagnose pneumonia on ultrasound. You can diagnose pneumothorax on ultrasound. They can teach you how to look and find veins on ultrasound and put up IV lines for your patients, especially if you've got the linear probe. They can teach you how to look for DVTs. They can teach you how to look for aortic aneurysms, which I think it's extremely useful, especially if in the rural hospital you've got the ultrasound machine. It's just there, and you can practice these skills. It's something that I would really advise you to do if you've got those equipment at your setting. I've put up, and I've given this slide also to Madeleine to distribute to you. This is just contact details of all these courses. The Resus Council, they've got a lot of these courses. They also house a lot of training centers that does the American Heart Association courses. So if you want to do ACLS, PALS, all those things, go to the Resus Council website and they will help you there. All the others you can just scan and use as you seem fit. Also remember that Resus Council provides the algorithm posters for free. So if you think back of your setting, if you see these old navy and white posters, they're out of date. You need to get the new ones. And you get them for free from Resus Council. You just need to phone them and ask for them. They'll really give you all the posters for free. The only thing is you need to arrange pickup. So you can either arrange from someone that you know that can pick them up for you, or you can arrange for a courier company to go and pick them up from them. But please make use of them. They're also available for free on their website. I've also downloaded them and given them to Madeleine to distribute to you. I mean, they're free for use. They're there for you to use. So don't let this opportunity go by. Get them for your facilities. Put them up on the walls. Look at them. Discuss them with your staff, and use them, because that's best practice in South Africa. And they've also, in some circumstances, they've added, for example, basic life support with communicable diseases, thinking about COVID, but communicable disease will be there forever. So they've got algorithms for those situations as well. Yeah, and that's basically my 5 cents for the evening. So I hope you learned something, and I hope you will at least change 1 or 2 things where you are going. But yeah, if you've got any other questions, you're more than welcome to. In terms of rules, if you would like to maybe start rules in your setting, make contact with us. We're trying to expand it nationally or roll out it nationally. But yeah, otherwise, you're free to ask any questions.
Oh, thank you very, very much, Jurgens. That was a great roadmap, actually, because it's impossible, of course, to cover it all in a short presentation, but it was a really nicely filled with top tips. And I think this last section and pointing people on where to go next in terms of training was very useful. We're just doing a quick feedback poll. In the meantime, if you do have questions, please put them in the chat for us, or you can just unmute, or you can put a hand up. We're quite flexible here. I can already see some people saying thank you on the chat. And yeah, very good, excellent feedback on our presentation in terms of it being very useful for our rural doctors. And then what will happen next is tomorrow you'll be getting 2 packs this week. The one will be a resource pack on emergency medicine. So sending you all those wonderful links, both free links, and there's also the Western Cape's got a very good emergency medicine textbook, which one can buy at cost price from the Western Cape. I'll send you all of those links and everything as well. And then our other presentation, our other resource pack is going to be on non-communicable diseases. And just like some of the key essential stuff, of course, we're not going to cover the whole spectrum, but key stuff that you might find useful and key links that you need to have. Our next presentation is actually going to be a combination of emergency medicine and NCDs. On Wednesday night, we have Prof. Parrish, who is our HOD in internal medicine here, professor in internal medicine at WUSU, here in East London, actually. And they've set up an amazing project called BAMSI, where they've been providing support and outreach to our rural district hospitals from the internal medicine department. And he's going to come and speak specifically on internal medicine emergencies and going into a little bit more detail on some of those. So we look forward to seeing you on Wednesday night. And again, it will be recorded for those of you who might be on call or who might be busy. Yes, so thank you for the feedback. So yes, this presentation, excellent. Lots of, I'll just share the results there. And yeah, Jurgens, you've got it at exactly the right pitch there. It looks like people found that very, very useful. So excellent. I'm not seeing any questions on the chat, and I haven't noticed anybody unmuting themselves or jumping up and down. So I'm going to say thank you, so people can actually go off and get to your Valentine, hopefully still get to your Valentine dinner in time, or at least give your mom a phone call. And we hope you have a lovely rest of the evening. Thank you very much.
Thanks, guys.